Good afternoon. Today's Battle Rhythm will explore the topic of suicide prevention screening and lessons learned by organizations who are conducting these screenings. We have an exciting group of panelists today that will provide insights on our topic. I'd like to welcome our moderator, Wendy Lakso, Director of Partnerships and Military Veteran Initiatives from the Columbia Lighthouse Project with Columbia University and the New York State Psychiatric Institute. Please feel free to add questions and thoughts in the chat box as we go, because we can address these questions at the end of today's panelist discussion. I'm going to hand the presentation now over to Wendy to tell us a little bit more about herself and to welcome our panelists. Wendy, you have the floor.
Great. Thanks so much, Allison. So good afternoon, everyone, and welcome to today's panel discussion. I'm Wendy Lakso, like Allison said, from the Columbia Lighthouse Project. And I really am honored to be here today moderating this important conversation on behalf of America's Warrior Partnership during Suicide Prevention Month as well. So as we know, suicide does remain a significant public health crisis, especially among our nation's veterans, service members, and their families. Today, we'll be focusing on one of the most critical tools in suicide prevention, the integration of suicide screeners into various systems of care. So today, our panelists will share their expertise, experiences with integrating a screener across clinical, non-clinical, and community platforms, and discuss what they're experiencing, as well as some outcomes with the integration of their screening. So before we begin, I'd like to briefly have our esteemed panelists who do bring very diverse perspectives to this conversation to introduce themselves. If you could just tell us your name, organization, title, and a little bit about what you do. I'm going to go around the panel. So let's start with Jeanette.
Good afternoon. I'm Jeanette Gilles. I'm a clinical social worker here at America's Warrior Partnership, and I'm the director of our network. Our network is a digital platform. Folks reach out to us for assistance, and we connect them when local resources are exhausted.
Super. Thank you, Jeanette. How about Dave?
Good afternoon. I'm Dave Lewis. I'm the Executive Director of the Harris County Veteran Services Department. Harris County is basically the county that has Houston, Texas in it. About 1% of America's veterans are within 15 miles of our doorstep. And we have basically 3 lines of service in our department. I work directly for the Commissioner's Court in the state of Texas. Every county is run by a county judge, kind of like the executive leader of the county, and then 4 commissioners. So that's what we have. If Harris County were a state, we'd be the 25th largest state in the country. So we have a significant population here. In addition, we are grant as part of a Fox Suicide Prevention Grant. We serve all the counties that touch Harris County as well. As a veteran county service officer, we do claims and benefits. That's our statutory responsibility. We do lots of jail intervention for justice-involved veterans. About 2,700 veterans go through the Harris County Jail every year. We do suicide prevention, homeless prevention, and homeless services. And we have some emergency financial assistance pieces as well.
Well, thank you, Dave. It sounds like you're awfully busy down there. How about you, Dan?
Yeah, hi, everybody. So my name is Dan Siegert. I am with Wounded Warrior Project. I am one of our senior suicide prevention training specialists. Essentially, what we do is ensure that not only our teammates, coworkers are trained in suicide prevention, but we also reach out to community resources and partners as well. We provide trainings throughout the entire country. We have a very lofty goal of hitting every single regional office within the United States, in addition to Hawaii, and just working to expand as many trainings as we possibly can. I am personally from the Pittsburgh office, and in addition to the trainings that we establish, we also are working to incorporate the Columbia scale as far as a screener throughout multiple programs, in addition to the mental health ones that we'll definitely touch on later. So that's me in a nutshell. Thank you.
Super. Thank you. James.
Morning, everyone. My name is James Mulak, and I am the Director of Warrior Advocacy for Upstate Warrior Solutions based out of the upstate of South Carolina. We have offices in 4 counties, but we oversee 10 counties. I oversee all of our advocates across the entire upstate and all of our branch offices. And I head up the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant Program through the VA. Along with that, we also do, traditional advocacy casework in areas of housing, employment, educational resources, legal resources. We're highly involved with the veteran court system with our justice involved veterans and vet court, veterans treatment court, family. We serve families as well, and recreational opportunities and spiritual opportunities as well.
Super. Well, thank you all for being here today and for your commitment to this life-saving work. So let's dive into the conversation. So I'm going to go around the horn again. And I know Dan gave this away just a little bit ago, but I'm going to mention it. I'm going to ask, are you using a suicide prevention screener? And if so, what type of screener, or what's the name of your screener? Let's go backwards. James.
Yeah, so since being part of the Staff Sergeant Fox program, we use the CSSRS, the Columbia Suicide Severity Rating Scale, and we've been doing that since the inception of the program. We have not done any screeners prior because we are non-clinical based, but we've already discussed internally as good practice. If anything were ever to happen to that program, we would continue to use the CSSRS moving forward, just to identify any veterans in our community who are at risk.
Fantastic. How about you, Dan? I know you mentioned it a little bit, but can you go a little more detail?
So in addition to a lot of us, I think, also using the Columbia scale as well. So we use that currently as far as any mental health referral that comes through Wounded Warrior Project. There's several different avenues which they can register through us. And there's several different ways that they can indicate that they're interested in mental health. So currently we are doing a screening for initial intake with them, and then looking at the appropriate placement of programs. In addition to TBD, expanding to non-mental health programs as well to incorporate this screening to as many different aspects of Wounded Warrior Project as we possibly can. Great,
that's awesome. Jeanette, how about AWP? What are you guys using?
We use the CSSRS as well. We've been using it since March 2023 when we began the Sergeant Fox study. We do that on everyone who is who has an intake. So they go through our intake process. At the end of our intake process, we ask them the questions and screen them appropriately.
Okay. Perfect. Well, you're all making it easy today for me then. So when instead of calling the Columbia, I say Columbia Protocol just because it's quicker than the Columbia Suicide Severity Rating Scale or Columbia Scale. So for today's discussion, we'll say Columbia or Columbia Protocol so we all kind of understand what we're going to be chatting about. So this is kind of a 3-part question. And I will... I'm going to go around the horn with this as well, because I think this is a very important question. Jeanette, I'm going to start with you. So what outcomes have you seen as a result of integrating the Columbia Protocol and conducting the screening? Has it been easier for you or more efficient to identify individuals that may be thinking of, taking their life by suicide, using this screener? And if you have any data to share, please do that.
Okay. Well, since the study started in March 2023, we have screened a little under 2,000 people, and 369 were Fox eligible. Of those 369, I would venture to say there are a large number of those that we would not have known anything about had we not asked the question, because many of the people that are coming through are asking for a wide variety of things, and mental health may not be one of them. So asking that question of them allows them to talk about something that maybe they hadn't talked about yet, maybe something that they weren't intending on bringing up. But asking that question directly can open the door and allow them to let us know what's going on, and then we can start addressing that right away.
That's great. Super. Thank you for sharing. How about you, James?
So yeah, kind of same with us. So since we started screening in 2023, we've screened 2,254. We've seen about 3,100 veterans come through our doors, but of those 2,254 were actually eligible to be screened. Because again, we don't just screen, we work with all veterans, regardless of their discharge or stuff like that. So of the ones that were eligible were 2,254. Currently in the program, we have 173 that are active participants. That's 798 that did not present, and then everywhere in between kind of did that. Same with Jeanette. If we didn't start screening, we would have never known this. Because again, being non-clinical, that's not something we were tracking. Obviously, other resources in the community were doing that, but we're just another force multiplier in the community to identify veterans who are at risk and then getting them into the help they need. So.
Super, super. And I love this data. This is fantastic. Dan, how about you in WWP?
Yeah, so we actually initiated the rollout of the Columbia Protocol October 1 of last year.
Okay.
So the data that we have collected goes through, that's the beginning of our fiscal year. It goes up until I believe the end is July. So data from then, we've had just a little over 400 or 4,800 screened. Of those, we've had 110 high risk. We've had 748 moderate risk, 519 low risk, and then we have just a little over 300 or 3,400 unreported risk. So that's where we're at with the numbers. But as I said, we're continuing to collect data on this as far as increasing the scope of how many people are screened throughout this. So we hope to increase those numbers.
So how about with you too? Do you find it's easier or more efficient using the tool?
Yeah, so it gives us a more centralized, or not necessarily central, a more structured format to follow when not only gauging like suicidal intent, but like the severity of it, right? So we have found that there's a lot of good responses, not good responses, you know what I mean though, but as far as like positive responses where it's like, okay, the indications of the level of care needed. So I would say it's helped with that as well.
That's awesome. That's awesome. Dave, how about you in Harris County?
So I can't tell you the exact numbers like everybody else is telling you to right now, but here's what I pay attention to. We used to lose a veteran every 6 days in Harris County. We have a direct working relationship with our medical examiner. And what we have seen, not saying we're everything about suicide prevention because it's a large community, but what we have seen between 2022, the first year that we were in business, fully 2023, a 32% decrease in veteran suicide in Harris County. That is significant, and we're very proud of that. What we try to do data-wise, the Columbia tool is very important to us, and what we try to do is to get our younger workforce not to just think of it in the Fox grant as a collection of checklists that I need to go through, but to facilitate a conversation and making sure that we don't miss anything in that conversation by backing it up with that Columbia protocol here. But we also know that somebody could pass a Columbia protocol 1 week and be very suicidal the next week. And so having that ongoing conversation with people is really important to us as well. We've also instituted kind of an internal protocol where we just use it internally, again, for our younger coordinators, screeners, if you will, to help them identify when they might need to ask for additional assistance or potentially get 988 on the phone, that sort of thing. So it helps a younger workforce to be a little bit more focused than somebody that maybe has 15 or 20 years of experience doing this.
Yeah, and I love that you say too, Dave, that you use it, you know, to have that conversation, right? Because we know that suicide is not a straight line. People aren't suicidal all the time. It's like everybody's emotions, right? They kind of ebb and flow. So I like that you use that continuously. That's fantastic. So let me go to, actually, Jeanette, before I forget, you said something that I just want you to elaborate on. You said Fox eligible. What did you mean by that? Just for individuals out there who kind of don't know what that means.
If they answer yes to any of the questions that we ask them.
Then they're Fox eligible. So when you mean Fox eligible, I'm confused by what that means.
Okay, so we do the screening questions, and if they say yes to any of those questions, then we talk to them about the grant and whether or not they're interested in participating in the assessment. The assessment is a series of over 100 questions. We ask them if they want to participate in that. We talk to them a little bit about that, and they'll either say yes or they'll say no. If they want to participate, then we move them forward, and if they don't, then we still follow them, and making sure that they're getting connected to resources, making sure that they're doing okay and things like that. So they're really kind of coming into a program.
Okay. Got it. So, and then you kind of wrap resources around them, right? Everything that they need. Okay, perfect. Just wanted to make that distinction because I know there could be some folks out there that weren't quite sure what that meant. So let's stay with you, Jeanette. Did you have to overcome any challenges or barriers when you implemented the screening protocols with your staff?
Well, I think everyone was a little bit nervous about asking these very direct questions. You know, the first one starts with, have you ever wished that you could go to sleep and not wake up? I mean, that's a pretty in your face, direct kinds of question. Right. So I myself was a little bit uncomfortable asking someone flat out that question right out of the gate. But after just a few times, and the staff, again, as well as myself, after a few times of asking, got comfortable with it. And really, it's a matter of getting comfortable asking the question, because if you're not comfortable asking the question, then you could influence the kind of answer that you're going to get. So I want people to feel that we know what we're doing. We're asking you this question, and we're prepared for whatever your answer is. And we will do what needs to be done when you give us that answer.
Perfect. How about implementing it within your systems? Sometimes I know people have it on SharePoint. They're using all sorts of different systems, and it's hard sometimes to implement it within a system. How about that? Did you have any difficulties or barriers?
Honestly, that was probably the easiest part.
Great.
So we didn't have any issues with that. Our tech folks are pretty good, and they're always updating our system and trying to make sure that it's the best that it can be. So William got it in there, and any kind of updates that it's needed, he's been Johnny on the spot with it.
Great. Shout out to William. Awesome. James, how about you? Let's go over and ask you those questions as well. Did you have any barriers or challenges implementing this with your team and your systems and protocols that you already currently have?
No. So fortunately for us, we already had a crisis intervention protocol established with our SPC, with our local VA here. So we already worked with them to create a policy if anybody were to present that was at risk, how the VA wanted us to respond, and how to connect them to the VA. So once we got the program, all we had to do was just alter the program to fit the parameters of the grant itself, and then move forward, and then just train the staff to it. But like Jeanette, same thing, getting out of the comfort zone. It's the first time we were asking those, heavy questions. Right. And then, we realized, half our staff are veterans. Every time we go to the VA, they always ask us that. It's the first thing to do. Veterans, I think, we forget to realize that veterans are asked those questions so often that it's just another day for them. It's just now us as non-clinicians asking those same questions, getting out of that comfort zone. And then now it's no problem whatsoever, because we all understand the importance of the program and how important mental health is with the veteran community. And so there really were no issues with that. And same with the system, implementing it in the system, just a few data points added to our already established system, just so we can track some internal data, and we kind of just carried on with like any other program that we operate within the organization. So
great. So I'm going to stay with you, James, because I know you've touched on this, and Jeanette did as well, but touched on this specifically about kind of getting your staff comfortable, right? I know that you don't need to be a clinician to use the Columbia Protocol. I am not a clinician, just so everybody knows, and I've been doing suicide prevention and using the Columbia for many, many years. So you don't need to be a clinician, but I know Upstate Warrior, most people think that you do, and most, I know organizations do have their clinicians do that, you know, do the screening. So Upstate Warrior Solutions is comprised specifically of non-clinicians. You said veterans as well.
Yes.
So in your experience, what role does staff training then play in the effective use of suicide prevention screener of this piece of it? And what kind of training do you recommend? What did you guys do?
Sure, yeah. So when we started everything, we already had a onboarding intake process in general. So all our staff is trained to conduct intake and that need a need approach and build rapport and have that, you know, that face-to-face setting where we're, you know, bringing them into the organization and into the fold of what we do, and then building in the program itself to ask these questions. But also, you know, we did the practical application, and then we took it a step further where we had all of our staff attend assist trainings. And then we actually had 2 of our staff go to train the trainer assist training. So now we have embedded staff to go ahead and do those suicide prevention trainings throughout our community. So again, it's, you know, we're malleable. We go with the flow, us veterans. And it's, you know, it's important work. So we do what we can to ensure our staff are prepared to be able to ask those questions. And, you know, with looking at it, you don't need to be a clinician to care about somebody, to care about their well-being, mental well-being. And we're all here for a specific reason. We want to help each other, and that we get to take it one step further with all these screeners and these tools, and allow us to identify veterans who are in need and connect them to those right resources. So
fantastic. And I'll follow up with right resources in a minute. But Dan, let's go to you too, because I know you had touched a little bit on the expansion, perhaps, right, of what you're looking to do. So what do you do right now as far as training for your team to get them comfortable role playing or whatever that may be? And what are you looking to do in the future?
Yeah, so great question. As far as right now, excuse me, when we initially rolled out the Columbia protocol, it was specifically dedicated to our mental health triage team, right? So these are various backgrounds of whether they are clinicians all the way up from the PhD level all the way down to, you know, just basic mental health. So initiating the protocol, it was, I wouldn't say that there were any barriers getting that out there, because the teammates were already asking about suicidality and thoughts like that. It was just more of a structured questionnaire, basically. And I will say the only issue that we may have had implementing that was the flow of the intake, right? Just because it was very structured. Again, these are very professional teammates and whatever, and they were able to, I think we attended a Lighthouse training with it, and there was some role play involved with that. But we also, our triage team, who again is primarily doing this, they're conducting the screening, each individual teammate, anywhere from 5 to 9 times a day. That's the average referral that they get. So that being said, with the mental health teammates and that, what we're looking at doing is expanding that to our financial education and our physical health and wellness programs, right? VA has indicated that chronic pain, lack of sleep, financial issues are some of the highest indications of suicidal thoughts. So, you know, when people come to Wounded Warrior Project, they don't necessarily always ask for mental health support. They might be looking for some of the physical aspects or the financial aspects. So really what we're trying to do is expand that screening to the other programs as well. Because we're not capturing that if they're not asking for mental health. So that's kind of in the future of what we're looking to do with like rolling out within the excuse me, the next few months of additional programs. To answer your question about the training, we are going to touch base with the leadership about them. Any questions, because these are not mental health teammates, but we think it's important. Like you said, it's not a mental health tool for
Correct.
professionals only. So I think
Right.
overcoming some of that hesitation is going to be a barrier. But then again, we also, I think, like, somebody else said, all of our programmatic teammates are being trained in assist. That's one of the major goals that we have. So not only are they prepared to ask the questions, but they know what to do in the event of some of the answers that might be a little bit more difficult to deal with.
Super. So great segue for me. Thank you very much. And I will stick with you then on that. But I'm going to ask everybody this question. So if you identify somebody who may be at high risk, what do you do then? I know I get asked this question a lot. Like, what do I do? I know 988's out there. Sometimes veterans don't like you to connect with 988. So what do you do with at WWP?
Yeah, that's a great question too. One thing that we've noticed conducting these surveys is high risk does not necessarily indicate imminent risk, right? One of the things we've also seen is that this could be a baseline of the warriors, and we also expand this to family support members as well. By that, it's caregivers, loved ones, etc. But necessarily like imminent risk, yes, we're initiating, welfare checks, we're following procedures for activating emergency services. But other times we've seen a very high percentage of people that are high risk are already engaged with not only mental health, but also psychiatric help, right? So they have medication management.
Right.
They also have connection to therapy through the VA, private sector, etc. So really kind of meeting when where they're at and looking at additional programs, right? That's why I talk about like the physical health, the financial education. We have an alumni program that really connects for like that social engagement and support that is something that's very helpful. And then again, basically, we have a number of different programs as far as mental health, but, looking at what is going to best suit them, we do a full intake and give a brief of what the programs are and what they might be best suited for. And I will say this, in addition to the highest risk, right, that might not be imminent, say they're substance dependent, right? And looking for inpatient. We have a program called our Complex Care Coordination Team. That is going to be the referral for the warriors that are most at risk, but are not in immediate danger. That provides case management, connection to resources through the VA, local situations, or places that are available, inpatient, IOPs, et cetera, right? So looking at a higher level of care, but again, just basically looking at the indications of suicidality, what supports are already in place and what is missing and how we can fill those gaps.
Great. And I love that we're going around and talking about this because you're also sharing your organization's programs and things that you can do to support our veterans, military, and family members. So I love that they can reach out to Wounded Warrior Project as well if they need some help. So let's go to you, Dave. What do you do in Harris County?
So I have a staff of 25, and someone who may be potentially suicidal may not present to my crisis team. They may present to one of my claims and benefits advisors. Right. And so teaching people and training people to help peel back the onion a little bit and get down to that. But probably several things. And I love that Dan just talked about, we call it a complex case coordination, the triple C kind of thing. Some of us have a lot of experience doing this. Some of us have very little experience doing this in our organization. So making people feel comfortable that they're not solo when they come across somebody, that they can bring in other teammates. Everybody in our office has the right and the responsibility to contact 988 if it feels like it is imminent. We've done that several times, very successful every time we've done that. Sometimes it's uncomfortable for the veteran. We also help try to target, and I'll talk more about this later if I can, the veterans' inner circle and family members as influencers, particularly when it comes to lethal means safety. So
Great.
we can help do that. But try to have that conversation. So as we peel back the onion, motivational interviewing, that sort of thing. And then one thing that I learned from another organization, and I don't remember where, when somebody is in crisis, sometimes we get very prescriptive. You know, you need to do this, you need to do that, you need to do that. We forget to ask the veteran, what do you need? What can I do for you right now? What's the most important thing you need right now? And it's really important because rather than, you know, we're going to come get you, we're going to do this, we're going to do that, rather than being prescriptive, give the veteran a chance to voice their needs and then tailor your response according to that. So, you know, and then assessing the level, whether it is somebody who is considering it, whether somebody that's in imminent danger. We're a large urban population and the area is big. So the thought of us being able to get physically to somebody in a timely manner may not be realistic, but we have great working relationships with our local law enforcement officers and trying to develop that as well. We have a lot of good mobile crisis outreach team people that we can refer people to as well. But basically having that conversation, I always talk about ask, respond, assess, you know, so respond, validate what they're doing, and then try to assess that risk level, figure out where we need to go next. But I love what Dan said. Look, if it's complex, you're not solo on this. Let's pull in everybody if we need to.
Yeah.
We can figure it all out.
Yeah, and I really like what you say too. You know, I mean, both Dan and you have had some really great talking points here, specifically with ask the veteran what they want to and what they need right at that time. I know it's so important too to make sure that our demeanor is receptive for that veteran as well, right? Or the family member. Just making sure that it's not time to tell our story, right? But to connect with them could be important, but not try to overshadow what they're trying to tell you. So I think that's great, and ask them what they need. Perfect. Thank you so much. James, let's go to you. What do you do after you identify somebody that may be high risk or at risk for dying by suicide?
Yeah, so for us, since in the Upstate, we don't have an emergency room with the VA. We have 3 small C-box. So that was our biggest question when we were working with our suicide prevention coordinator for the area. Is we knew everything that if someone was in crisis, our protocols, but someone who's low, moderate, or high being, if they're presenting at that moment, we don't even try to finish the screenings. We try to get them into a facility the best we can. And hopefully they go willingly. But if they're in a significant crisis where they've thought about it, they're making plans. They're reaching out as a last chance to kind of sway away from it. We're getting law enforcement involved. We're doing a wellness check, and we're hopefully getting them EPC'd over to a hospital, and then getting them to treatment the same day. And then we try to follow back up with them. Moderate, again, it's what they want to do, where they are at that time. And we are very high touch with those clients as well. We're consistently and constantly checking in on them on a weekly basis, multiple times a week. Low is it presents with, if we can get you into treatment, this is what you're looking for. But there's other things like, I'd be fine if I was employed, or I was just in a better situation financially in my life. And they've just got these stressors that they're not, there, but that question always lingers in the back of their head. So, and we've seen them all, and it's very delicate. But it's communicating with that client, finding out what's best for them at that given moment, and working and case managing them through their problems, and hopefully mitigating any barriers that they have, and ultimately, improving their life within a few weeks. But anybody who's high, it's really based on where they're at. And as an organization, if we feel if we need to get them somewhere immediately, we have the resources in place to do that and get them into treatment same day. So
I know that your organization is very, very connected with the VA.
Yes.
Has it always been like that? Is that how you just kind of evolved and developed it, or is it something that's been semi-recent?
Yeah. So our president was when he was on active duty orders, he was the DISC for the Marine Corps Wounded Warrior Regiment, which is the district image support coordinator. So he was already doing that work with the VA in the community, and they'd established headquarters in Greenville when he, developed Upstate Warrior Solution. So he himself was very heavily connected with the VA. And then as staff came on, it was our responsibility to continuously meet with the VA, meet counterparts, and who we can reach out to and have those. The backdoor interest is to, getting into the VA and making those phone calls and having those right connects to make sure we're supporting our veterans in the community. So yeah, we've been very well connected since 2010 now. So
yeah, wonderful. We hear, some things about the VA. We hear veterans don't want to go to the VA a lot of times, but we know that they do some great work, right?
Mhm.
And those veterans that do go to the VA get seen, and they really are taken care of. So I love that you're very, very connected with them in the CBOCs in your area. Jeanette, let's go to you. What do you do when you identify and your team identifies individuals that may be at risk for dying by suicide or imminent risk?
Well, again, identifying the level of risk that they're at, determining what do they already have in place. Are they already in treatment? Are they on taking medications? Do they have an appointment coming up? Who is their doctor? Where do they see them? Kind of assessing that. Sometimes they'll have an appointment the next day. If they do have an appointment the next day, encourage them to go ahead and call and see if you can be seen today.
Right.
But depending on the risk, we'll talk them through that. Then if necessary, we'll bring the VA crisis line on a three-way with them. We don't have the advantage that Dave and James do. Dan and I are kind of in the same boat in that all of our veterans could be anywhere. They could be in Washington State. They could be in, down the road. So we don't, I envy the fact that they're there in a community and they can really wrap around them a little bit easier. But there's always the crisis line, and they are a huge help to us. We'll get them on the line on a three-way call. They'll talk to the veteran and kind of get them connected with VA resources. And then the other thing we could do, particularly if they don't want to call the VA, then what we'll do is I have a number of really strong national partners that can pull them into treatment immediately. Wounded Warrior Project is one of them. Got some good colleagues over there that can help us. We've got some with Summit Behavioral Health. I don't want to start throwing names out. Sorry about that. But Wounded Warrior Project is, of course, a really good colleague, and so are some of the others in the space. And there are folks that we can just pick up the phone and say, hey, I've got a veteran in Peoria, Illinois, or so in Washington State, and we really need some help. In that case, sometimes we'll stay on the line with the veteran, have one colleague on the line with them, another colleague calling and getting support and working it that way so that they're not alone. Now that's just, for a high risk, someone who's in imminent danger, but always making sure that they have what they need, and then following up with them later. If they're low risk, making sure that, are you going to your counselor? How's that going? What's going on? Do you need anything else? Moderate risk, making sure that they've been connected, maybe checking back with the crisis line. If you ask the crisis line to call you back, sometimes they will, and kind of give a little bit of an update. They can't tell you much. They can just tell you whether they connected with them. And then staying connected with our national partners that are working with them and making sure that they are connected and they're getting the resources and things that they need.
So you mentioned two things. So I'm going to just mention also, you had talked about that 988 will call you back sometimes, right? And give you kind of an update. And I think that's great. The police department does that as well. Mm-hmm. They'll give you an update if you request it. So know that if you do go through the police department, then they can let you know what's going on. And then it'll give you a little more intel on how you can reach out to that individual afterwards, a couple days later, the next day, whatever that may be, whatever is in your protocol, and see how they're doing and to see if they need any additional resources. So I love that you did that. The other thing that you had mentioned a couple of times is a three-way call. So, or we call that a warm handoff, right? Can you
stay on the line? I stay on the line and listen.
Well, explain that a little bit about what you guys do with that three-way call, because that's what I mean is staying on that line or that warm handoff.
Right. So I'll let the veteran know we're going to call the crisis line. Now, this is one where they have to agree. So they've agreed to call the crisis line. If they're in crisis, I'm not going to give them the number to the crisis line and say, hey, call them. And I'm also not going to let them off the phone and call the crisis line myself and say, call them. I'm keeping them on the phone with me. I'm going to tell them, I'm going to put you on hold. I'm going to call the crisis line. As soon as it starts ringing, I'm going to bring you on. I will tell the lady at the crisis line, I'll tell her what you've told me. And then as soon as I've done that, I'm going to be quiet and she's going to talk to you only. I'll stay on the line. But if they ask me to get off, I will have to.
Right.
And so sometimes the crisis line counselor will let me stay on the line, or maybe they'll forget that I'm on the line. And I just stay and kind of hear, what kind of things are being put in place. But other times they'll want to talk to the person in private. And so they will disconnect the call, which makes me a little nervous, and call the veteran back and then connect with them like that.
Right, right. Okay, super. Thanks for explaining what that was. I appreciate that. I'm going to go to, I will ask this question to everybody, but I'm going to go to Dave first, because Dave, you had mentioned, this is going back to your staff and how you teach them and work with them to have a conversation with the individual, right, who may be in need. So we know that sometimes those conversations can be can really kind of get in depth, right? Can be complex, can be a little bit triggering for some individuals too. Perhaps your staff may be struggling with some things, and they may hear some, difficult situations, I say, or difficult conversation. So how do you take care of your staff? And what do you do to make sure that, do you debrief them? Do they have a quiet place to go? Are they able to go for a walk, whatever it may be? So Dave, how do you do that?
So all the above. We do have a quiet place where people can
Great.
go be by themselves. I was a Air Force commander with 29 years in. I'm really good at the eyeball check to be able to take a look and see when somebody's not doing well, but all my supervisors doing the same thing. And then reinforcing that this is a difficult business. It's a very, very intense human to human business. It has to be, if you're going to do it right. It can't be an app. It can't be a widget. It can't be a whatever. So there are going to be some very, very difficult times. Each and every one of us, I believe, has had to learn how to sometimes leave those problems at work when you go home. We get some people that are in some desperate situations. And sometimes it's a real challenge not to take their problems home with you and go, if you only did this, if you only did that, and what if it did that. Most importantly, let me hit on something that we just did last week, as a matter of fact. We had a veteran that was in our program, lost contact with him. 5 months after the act, we found out he had died by suicide. And so in the business that we're in, I was in the fighter aircraft business, and unfortunately we lost people and broke things periodically. And so the way we approached it is to sit down and not, I think today's workforce is always worried about being blamed for something, but rather than blaming people, what we did is we sat down and we ran what I would consider to be an accident board. We talked about what were the facts that we knew before the veteran died, what facts have we ascertained afterwards. We tried to establish a very good timeline. And then we tried to go back and talk about what I call is the bucket. I'm not a clinician, I'm a simple guy. His bucket was full. All these life stressors, all these other things, maybe some mental health problems mixed in there. Could we identify what was in the bucket? And then most importantly, how can we learn as an organization and grow as an organization, realizing any one of us could have made, a judgment call or an error in judgment, but how do we go about doing that piece so that we learn and grow as an organization? And again, not putting the emphasis on the individual that was the primary case manager or whatever else, but rather trying to figure out what we as an organization. Look, as the department head, I own the blame. I told everybody right up front, the blame's on me. And so do we have better systems we can put in place? Do we have better things that we can put in place? Do we have better training that we need to go in? What can we learn from this? And I think that was so important for our organization. And then the one individual that did kind of have the responsibility, if you will, because they were the last contact with the individual, took them aside privately, make sure that they understand that these things do happen. 15 years of doing this post-retirement, that's only the second one I've lost that was in one of our programs, but it's painful because we all want to second guess. We all want to say, what could I have done differently? I wish I'd done this. But in a lot of ways, it's the same thing as a lost team with the family, trying to help them understand maybe you couldn't have done everything. And so did we do everything we knew to do, and how can we grow? So I think taking care of your employees, understanding it's a very difficult business, making sure we do those eyeball checks, making sure periodically just pulling them aside and asking how things are going. is really important. Hire good people, take care of the people, I always say.
I love that. And we know that no one is to blame. Okay, Dan, what do you do with Wounded Warrior Project when you have your staff that may be having, you know, these conversations with somebody that may be suicidal? How do you support
Yeah.
them?
Yeah, so we take that very seriously, right? So we're looking at like the emotional impact that it has on some of the teammates when they're making that call.
Yes.
We never know, and this isn't related directly to the Columbia scale. This could be a benefits interaction, right? When a warrior is talking about like all of their medical conditions and stuff, that can be very triggering, right? So a lot of times that can lead to a very difficult conversation with somebody that might not necessarily be mental health trained. So in addition to the training that we're doing, we kind of look at that as sort of like upstream prevention, you know, not necessarily for the warriors, but also to prepare our teammates that like, hey, you're most likely going to run into a difficult conversation, right? Especially
Right.
when you're talking to X amount of warriors per day. So one, we follow the Living Works curriculum as far as training. So we offer the START, that's the online
Right.
90 minutes at your pace is kind of like the introductory level. All of our teammates that are onboarded go through Safe Talk, and we're actually looking at developing our own program and curriculum for that as far as explaining those kind of things. And then again, all of the warrior-facing programmatic teammates are being trained and assist. To follow up on that, just being prepared doesn't necessarily mean that you're able to handle yourself after
Right.
that situation, right? So
Right.
we're looking at post-vention curriculum where it's not
Super.
necessarily just post-vention for, okay, like this is for the people at risk and the family members, but also for the teammates that are having those interactions. Like, what are we doing to support them? A couple things that we're working on. Just a few weeks ago, we did something that's called Mission Fit. We had me and the two other teammates on the suicide prevention team here. We did an hour-long webinar about the importance of self-care, specifically hitting on boundaries, you know, taking care of yourself, incorporating that routine with the idea of like, hey, this is what compassion fatigue looks like. This is what burnout looks like. And here's how to kind of mitigate some of those kind of things, right? So we heavily stress the self-care aspect. We also are working to include a follow-up resource, not only for teammates, but also for, we have a lot of volunteers through Wounded Warrior Project that might run into some of these interactions as well. So that could look like getting connected to, you know, individual therapy through our EAP. Any alumni that is registered with us is eligible for short-term services. We kind of bridge the gap through our external partners for like outpatient therapy.
Right.
Trying to get to, you know, just get that kind of connection. And then another thing we're looking at is a manager follow-up. Anytime we have a crisis interaction or assist interaction, that is actually documented and followed through our electronic database. And we're having a manager follow-up or somebody that's comfortable with that teammate to debrief, right? Because no matter how long you've been doing this or having these conversations, you need to process that call. Otherwise, you're not going to be fit to continue with that.
Great. So
yeah,
you mentioned a couple of things, and I'm sure I thought I saw Bonnie Carroll's. She wrote something in the chat, and I will say that she'll be the first to say, you know, Bonnie from Tragedy Assistance Program for Survivors, being the first to say how important postvention is, right? And it's critical on the continuum of care, but it also comes in many forms, right? It doesn't have to be just after a death. It could be for something like this as well, when you're going through a very difficult time, difficult conversation, whatever that may be. You also had talked about that debrief follow-up with the manager who reaches out, and it's neat because I remember when I worked with the VA, and the DoD, it was something that caring contacts, right? It's that reach out afterwards, not only for that individual that could be struggling at the time, right? Or suicidal, but for the individual that's helping them as well and could be struggling just as much, right? With that conversation. So I love that you guys do both of those. That's fantastic. Let's go to James. James, how do you support your staff after a conversation like this?
Yeah, sure. We're kind of in the same boat. When we built the program, we had our staff in mind as well because they're going to be ones implementing the program. So we wanted to make sure that if there was a critical incident, we'd have a post-mention debrief, an audit of what's going on, because we really wanted to make sure we were taking care of our staff as well. A lot of our staff members who are client-facing or direct client-facing are combat veterans, and suicide is very near and dear and very close to them. And we knew that there was going to be a lot of stuff that could be triggering for them. So we wanted to implement as many things as possible to ensure our staff was in a good place to, carry on with the program. So we do staff trainings every single month, and we also offer our staff to go get some counseling services. We highly recommend if you're getting into the fields, let us know, and then we'll take on some of that burden to go see a clinician for 6 or 8 sessions at a price that we can negotiate with them, but the organization takes care of that for them. Again, with us in the veteran space, we do work with a lot of clinicians with the VA, the vet center, and stuff like that. A lot of our staff don't always want to go see them because hey, we're colleagues, and they don't want that struggle of, I work with you every single day, but hey, can we talk on the side because I'm really struggling here? We try to mitigate that and go to an outside source, someone that we don't regularly work with in the veteran community, and make them feel comfortable too. They don't want to be showing up to work and seeing their counselor that they're they're having issues with, and then all of a sudden try to put on this facade of everything's great. We all know that how that will turn out. So, but we definitely built the program around our staff and how to incorporate these self-care instances where it's going to happen. Someone's going to get triggered, and how do we best support them through, whether it be trainings or counseling sessions or just having them step back and, I take on that client and they kind of focus their attention somewhere else. So,
yeah. And you said it really is all about self-care, right? You said it perfectly. Jeanette, let's go to you and answer that same question around your staff. What exactly do you have certain protocols or what do you do with your staff to support them as well?
Well, the work, kind of like what Dave said a little while ago, the work that we do is very hard. Even when folks aren't struggling with mental health, there still might be struggling to prevent homelessness. There might be financial issues. There could be relationship issues. There could be a number of things. So I try to tell them to begin with, I'm a social worker. Some folks on my team are. So I just tell my team, people do not come to see social workers or any of us because they're having a good day. Something is going on, and it's really important to find out what that is. My team has been trained, and we do ongoing training. We're up for some additional training coming up in a couple of weeks. I try and support everybody, especially if I see on the team, if they're struggling, if they have a case that they don't know what to do with, or if they have a veteran maybe that's at high risk, as we've been talking about, because those really, it's scary. It's scary when you have that kind of responsibility and you're trying to help somebody get connected to important resources. So really supporting them, encouraging them. We had one last week where one of my team had a call, and she was very disturbed by the call and wanted to spend some one-on-one time in my office. And we just spent, an hour talking about it, rehashing everything, me reassuring her what she did was correct. And then after that, after we did the one-on-one support, letting her know that she needed to take care of herself. What do you need to do? Do you need to go for a walk? Do you need to go home for the day and take an afternoon? What do you need to do to take care of yourself? Because these things can accumulate. If you don't take care of yourself, it's not just going to go away. It's going to stay there and it's going to build. So you really need to process it and understand what happened, understand that there's a lot that you can do, but there's a lot you can't do.
Right.
One of the things that we have to do is take care of ourselves, because we want to be healthy, but we also want to be able to do this work. And in order to do this work, you have to take care of yourself. If you don't, you won't be here very long. You'll burn out on it.
Right. And, you know, I was going to wrap up this conversation and talk about what you can do for yourself, but Jeanette, you said it perfect. So thank you. I don't have to do that. I am going to ask one last question to each of you. And I know this probably wasn't on our list, but I'm just going to throw it out there. What stressors, what issues are you seeing most prevalent with our veteran population or their families today? Jeanette, let's start with you.
A lot of financial, a lot of not having a job, not being able to get a job, and then the financial waterfall, so to speak, that happens after that. So seeing a lot of that, also seeing a lot of access to mental health care. You know, and I'm not picking on the VA, I'm just saying across the board, even in civilian healthcare, access to mental health is difficult. My sister was telling me earlier today that she was trying to set up an appointment for herself, and she couldn't figure out who was going to take her insurance and where to go and what to do. And so it's really hard to navigate that system. And I'm a social worker. I've been one for a long time, and it's hard for me to navigate it at times.
You're right. It is a difficult system sometimes to navigate. Let's go over to Dave. What stressors and things, and I say this so everybody's aware, right? So we're kind of more aware of those stressors that we're seeing. I mean, we know that, you know, social network is important, things like that. And if you're in a rural area, but we're hearing a lot of financial, and that's why I wanted to ask the question, because just if we're aware of those prevalent issues or stressors, I think we're more apt to be able to reach out as well if we're hearing things, right? So Dave, let's go to you. What are you seeing?
So the big three, probably what everybody else sees, but specifically, we see financial issues, relationship issues, and then I'm going to say we see a lot of justice issues. And a lot of the justice issues are offshoots of what I call numbing, and that's people that are drinking or using other substances to mask what's going on here. But specifically, our framework talks about find, assess, stabilize, treat, and then we look at reassess. We have a 16-point, so build on your strengths, try to figure out what else has happened, where are your vulnerabilities. If you want a job, you have transportation, and then try to get them reintegrated back into the veteran-based community, not just reintegrated into the community. So our whole framework is designed to look at that, but the big three, again, financial, relationship, and justice issues.
Thank you. And I like the fact too that you talked about, you know, that you're always with that individual, right? To get them care and the help that they need after your original point of, of conversation with them too. So I really, really like that. James, what are you seeing? Are you seeing anything different? Let me say that. Are you seeing anything different than what's already been said?
No, but to go a little bit deeper with that, and when I do this in training for crisis intervention and stuff, I have to remind our staff or new staff that when someone's in crisis, that crisis might not look like a crisis to you because maybe you've experienced something in your life or you're used to it. But that's the end of, I mean, they've never experienced something like that before. And that's a real crisis to them. So identifying that a real crisis to someone just because you may not realize it is. And I use this, scenario all the time. You know, we always work with population, especially being in the social work field, underrepresented communities, and someone who's grew up in poverty, that's all they've known. And so they're used to something like that. When someone who's never faced that before, and now they're out of a job and they don't know what they're going to do. Someone who, is in the field who, maybe they grew up through poverty and now they're working and they're in this field and they see that, like, that's not a big deal. I didn't know when I was, I went to school getting a meal. That was a normal for me, but for someone else, that's the end of the world. So just training our staff and making them understand, no matter how big or little that crisis is, it really is, their world is crumbling around them, and you have to have that genuine empathy for that individual to be able to assist them and identify the needs that they're looking at and come from that compassion standpoint.
Right.
Everything is always revolves around financial. I think today, anyways. You know, the way the way things are now. I mean, I think everybody is kind of hurting in some way. You know, prices are kind of crazy. Things are a little bit out of whack. So I think we're always going to see those big three: mental health, you know, SUD, and you know, homeless, which can go hand in hand with, you know, the income. So
right. You said it very eloquently with your just empathy. Really, that's the big takeaway there, right? Making sure that everybody approaches everybody else with empathy. That's awesome. Okay, who did I miss? Dan. Are you seeing anything different outside of what we've already heard?
No, I mean, 1,000% of what everyone else has said, right? So I won't reiterate everything that they said. The other thing, the one thing, and I know I touched on this a little bit before, as far as stressors we're seeing, is the chronic pain aspect, which you don't necessarily see as a mental health condition that would necessarily lead to suicidal thoughts. But let's face it, like in addition to sleep, if you're not sleeping and you're in a chronic pain, like life is not good, right? So that is one thing that we are definitely taking indication of, in addition to everything else. And that's something that we're really looking at, because like traditional talk therapy isn't going to help with chronic pain, right? So we're looking at our programs of like I said, with physical health and wellness, it helps with like sleep hygiene, nutrition, exercise, those kind of things. And then isolation. We've noticed as the big thing, like that lack of connection. So we have an alumni team that their job is basically outreach, and it's like, hey, let's get people involved with the community. So that's something that we're seeing as well. Is like I said, I think everybody hit on aspects of it, but like the two, I felt like maybe we didn't hit on as much is that chronic pain aspect, and in addition to the isolation, and how we're looking to mitigate those as well.
Yeah. And I think you're right. I think it's kind of intuitive, financial, right? It is intuitive. We've heard it for a long time in this space, individuals that are suicidal, some of financial, legal. But I like, you know, that isolation, living in a rural area, the lack of connection, that social support, right? Chronic pain, very, very important too. And sleep, we know is a factor too. So I just love all of those. Substance, you know, misuse, which can get you involved with the justice system then, right? I mean, all sorts of things around that as well. So thank you so much. I know that we probably have a couple of questions, or I know that we had some questions at the beginning. Allison, do you want to throw up any questions or talk about any, or read any of the questions that we may have?
Sure, I can do that. I know that there was one that came in during the registration that asked about how do you support less experienced staff with the protocols? I know that we've talked about training, but is there any other things besides trainings that our panelists do to support their less experienced staff, or maybe less clinical experienced staff?
Well, for me, because I have interns, I just keep a close eye on everybody, honestly. And if I know somebody is interviewing a veteran who is at risk, or they've had somebody that they're worried about, I just stay close to them and make sure they're okay, and make sure they're taking care of themselves. And, you know, again, this is hard. We've got to take care of each other.
Dave, I know you just had your hand up as well.
Yeah, I was going to say periodically, what I try to do is to have a sit down with everybody and kind of talk about our big picture and how everything integrates together, and how their piece of the puzzle fits into other pieces of the puzzle, with the intent of really trying to break down barriers within our own organization, and then figuring out not only that internal friction, but what are the external friction pieces, so that we can kind of understand, why does the VA do what the VA does? Sometimes they have a perfectly good reason, or sometimes, you know, a law that prevents them from doing certain things. So how does that as trying to grow them, not just to screen people for suicide, but to say, how do we fit into the bigger picture in the overall pieces? It's a complicated business. There's lots of parts. There's lots of different organizations. And then the last thing I wanted to say is Dan was talking about isolation and it came up about rural areas. People hide in plain sight in an urban area as well. Just wanted to throw that out there. And sometimes that's more difficult there than the rural veteran.
Very, very true. Thank you for bringing that up. I appreciate that. Allison, anything else?
Yeah, Michael Tepper asked, does the Columbia Protocol screen for relationships, strife, and dissolution?
So the Columbia Protocol builds upon itself with thoughts, right? And then intent, and means, and then intent. So thought, means, and intent, and it builds itself upon itself like that. It's the conversation that you have that brings out the rest of that, right? And that's the conversation that from my understanding here, everybody's trying to train to, right? And prepare individuals for as well. It's that conversation that pulls out that information. Does anybody have anything else to add to that? Dave, I think Dave did.
Well, it triggered another thought in my mind here that conversation is really important. But when I talk about suicide, I always try to talk about the intersection of two things: the desire to end your life, the will to die, and the lethal means available to you. And so I just wanted to throw out a resource for people. We have a thing called the Texas Two-Step. It's tx2step.org, and I'll throw it in the chat. But it's secure the means, reach out for help. And so we've put billboards up. We've done a lot of different things to try to get people to drive to that site. But it kind of diffuses the conversation about, there's a gun in the house, you're probably going to die by suicide. No, if you have no intent, or if your intent is extreme, then we're going to do an emergency detention on you, right? So somewhere in between those two pieces is that conversation and trying to understand and unpack that piece. But I'll throw it in the chat so people can see it.
Thank you. That's great. I look forward to looking at that resource.
I'm hoping that Karen could share. We have one of our organizations is in the Navajo Nation, and they had to really overcome taboo because it's part of their culture was to not talk about and ask the questions. So Karen, can you share a little bit about how organization or what motivated your organization to be able to overcome that obstacle?
This is Karen. I'm with the NENOSPA Partnership. And the taboo and when we first started with the suicide questions, it took me a while to get used to saying that. And then I would question my father as he was a veteran and asking him these questions. It was kind of like, don't ask. And it's like, it's something you don't talk about. That was my 91-year-old father. And as the times went through and asking these questions to our veterans, it came really, it came out okay to ask these questions, and they understood now. So it came, like I said, it came out, it took me a while to ask these questions, but now, so far, when I do the intakes to our veterans here on the Navajo Nation, so far all the answers I get are no, because these veterans actually have families that they think of and their children. So even if a veteran is by themselves, they don't have that idea of committing suicide. So, and then if they do, so far, like I said, I haven't got any veterans who are suicidal at this time. So,
yeah. So I don't know if that's a great thing. And I'm just going to kind of respond to that. I don't know if that's a great thing, right? Or maybe it is that cultural difference, right?
Yeah.
And how do we work around those cultural differences and sometimes barriers, right? To be able to say that they need help. And golly, Allison, there's your next webinar. I mean,
Right. Overcoming cultural barriers.
There's so much that can be said around that, and I appreciate you bringing that up, Karen.
Yeah, you're welcome.
Well,
Yeah.
one of the things too that happened, one of the lead for the organization had a nephew, I believe, that actually did act upon the desire to end
Yeah.
his life. And so I think it was that too was sort of like, okay, so this may be something that not everybody's comfortable with, but we have to ask.
Yeah.
Yeah. Yeah.
Because if we don't ask, we won't be able to help and assist and get veterans the help they need.
Right. And the more we talk about it, right, it destigmatizes it. So the more we talk about seeking care, mental health, just no difference than if you fall in and break an arm, right? You go into the doctor, same thing. And I know I'm talking to the choir here when everybody, you know, preaching to everybody who already knows that, but it really is. We have to continually reiterate it with all of our different audiences and the individuals that we associate with. So we can destigmatize this.
Well, I think we'll go ahead and sign off for today. We'd like to thank Wendy, Dan, Dave, Jeanette, and James again for the informative panel discussion. Our next battle rhythm will take place October 7th. It is focused on improving the life for elderly veterans. So we hope you can attend that. Thank you all for collaborating and sharing. America's Warrior Partnership's ultimate goal is to improve the quality of life for veterans and end veterans in suicide by empowering local communities to know all the veterans and serve them holistically before a crisis occurs. America's Warrior Partnership's model, community integration, applies local effort by bringing together community veterans serving organizations to bridge the gaps in available services and to connect local groups to national resources. We believe that communities are best equipped to improve the quality of life for veterans, and we hope that today's battle rhythm provided you with powerful insights, best practices, new partners, and tools to do just that. Thank you guys. Have a great rest of your day.
Thanks so much.